All right. Welcome, everybody. Good to see everybody. Welcome to our March Wall Family Speaker Series on Health, Spirituality, and Religion. We are really happy that you're with us today. Some of you are aware, once a year, our Wall Family Speaker Series hosts a special session where we highlight the projects that are done internally here at the University of Michigan, specifically projects that speak to the intersection, of course, of health, spirituality, medicine, religion. And we really try to focus on projects that are either being done by medical students, fellows, trainees, to highlight the good work that they're doing. And so today is that session, one of our favorite sessions. So before I introduce our speakers, I just have a couple announcements. So for April's session, we are really thrilled to be hosting Dr. Laura Vater. She is a writer, she's an advocate for clinician health. She is an oncologist at Indiana, and she'll be speaking on finding joy, meaning, and health in clinical medicine. She'll be speaking on April 30th at noon. Also, I will be on a panel with the historian of American religion, George Marsden. He and I will be giving a panel at the Michigan Christian Study Center here on campus. We'll be speaking on a generous pluralism, how Christian faith can enrich the university. That will be on Thursday evening, April 18th at 6 p.m. Registration is required, and you can find more information on our HSR email about that. Also, a lot of us here at Michigan Medicine are attending the Conference on Medicine and Religion this year. It's down in Indianapolis on April 14th through the 16th. And there's a lot of us going, and we have a thread going about who can carpool or share lodging. So if you're going and you're interested in being on our thread to sort of meet up and try to share resources, please let us know about that. And finally, Adam and I continue to hold office hours. We'll be doing that the rest of the spring, and you can stop by and chat with us, whatever's on your mind. We have our times, dates, and locations listed in our HSR email. And for faculty data, just a reminder, you can claim CME credit for attending today. All right, now on to our session. The way today will work is that each speaker will give their presentation for about anywhere from 8 to 12 minutes. And then we will do Q&A right after that. And Adam will go ahead and introduce our first set of speakers. All right, Adam, thanks.
I am very excited to introduce Rennie and Meredith, who are amazing M3s. They're going to be presenting to Build a Temple. Can our healthcare system promote holistic health? Just to tell you a little bit more about these two awesome students. Rennie is a current third-year medical student at the University of Michigan. She attended UC Berkeley for her undergraduate degrees in molecular and cellular biology and cognitive science. She is planning on applying into psychiatry with a special interest in working with adolescent LGBTQIA+ and female identifying populations. And Meredith is a N3 here at UMMS. She attended the University of Michigan for undergrad and majored in biology. She's planning to apply into dermatology. Without further ado, Rennie and Meredith.
Awesome. Hi, everybody. Thank you, Dr. Rue, for such a lovely introduction. Meredith and I are very excited to speak to all of you today on the small and simple question of, can our healthcare system promote holistic health? So I'll let Meredith get to the right place in the slides quickly. Also, if I intermittently have to move, it's because the lights don't stay on in this room. Okay, awesome. Thanks, Meredith. Okay, so before we get to the answer of this question, or the lack of answer, we thought it was important to first ask, what is the purpose of a hospital? Next slide. So one answer to that question comes from the American Hospital Association, who provide more of a technical definition, as you can see here, including things like specifics on bed numbers, organization of how a hospital should be, and what kinds of services are provided. Next. However, another answer that we kind of found when we were looking around, and one that's a bit closer to home, is more focused on broader values and goals. So you can see kind of one-liner versions of the mission and vision of Michigan Medicine at the top right of the slide. But we also wanted to include some of the more specific goals that are listed on the mission website because they were a bit more robust and fleshed out. And one goal in particular stood out to us, which is highlighted here, which states that we will be a place of belonging and inclusion for all and honor the well-being, individuality, and dignity of those who work, learn, and heal at Michigan Medicine. That was one in particular that we really liked and wanted to highlight in our presentation about kind of what the purpose of a hospital or what it means to be a hospital is. Next. However, we also want to know what all of you think about a hospital's purpose. I realize maybe you weren't expecting to be asked questions during our presentation, and there's no pressure, but if anybody has opinions on what a hospital's purpose is or what they think a hospital should be, we encourage you to kind of just unmute yourselves, shout some things out. I'll give you a few seconds to do that. Or people can put it in the chat and I'll just keep talking. Thanks, Dr. Collier. So Meredith, if you don't mind going to the next slide. So we had some of our own ideas about what we thought a hospital should be, which are written here. Some of the ideas that we had are, a space for healing, a place that provides physical, mental, and social resources, a place that improves health not only for individuals, but also for broader scale things like community and society. A place that doesn't just fix the problem at hand, but addresses the cause of the problem. Ones that we would hope everyone would agree with, like a safe place without discrimination. And then also a place that takes care of the people who are doing the caring.
Rennie, we also have some messages in the chat about hospital being a place of hospitality, as the name suggests, safety net, a place to welcome the stranger, the other, the unwell, a place that would be proactive rather than reactive, and an institution that facilitates community well-being. So pretty in line with kind of what we were thinking as well.
Yeah, and thank you everyone for sharing. It's lovely to see everybody's perspectives. So kind of taking all of those things that we thought of and you thought of together, it seemed to us that in its own way, the hospital is a temple devoted to health. It's a place that's built to advance health and support people's health as well as their relationship to their own health. So we thought it would be interesting to compare it to one of the original temples. And by that, we mean the temple in Jerusalem. So this temple was said to be built around 10th century BCE and was the spiritual center of Jewish life for quite a long time, for centuries. Presumably, they built it and used it as a place to bring the Jewish people closer to God. And as part of that process at the time, animal and produce sacrifice was used quite frequently to increase somebody's connection to the divine. Next. However, something we found interesting was that many prophets towards the end of the Bible, including prophets like Isaiah, Micah, and Amos, heavily criticized the Jewish people's worship at the temple. They raised questions such as the one that we included a screenshot of here, where Micah asks, "And what God requires of you, only to do justice and to love goodness and to walk modestly with your God." So essentially, these prophets argued that temple activities like the animal sacrifice that I mentioned had become the only forms of worship, and that after people left the temple grounds, they then acted in ways that didn't match up with Judaism's expectations for the Jewish people. In this text, the pursuit of justice and kindness and caring for the disadvantaged is described as the core of the Jewish people's relationship with God, not certain activities like animal sacrifice. Next. So we felt it was interesting and important to ask a similar question, like the prophets did of the temple in Jerusalem. Is the hospital as a temple fulfilling its core mission? And I will pass it over to Mary.
So Today, we will argue that the hospital system is falling short in key areas for both patients and providers alike. To start, we can talk about some more obvious shortcomings that happen when patients are actually hospitalized. In the hospital, patients can get hospital-acquired infections, they can develop new illnesses. Their sleep, which is a necessity to health and happiness, is frequently interrupted each night with lab draws and obtaining vital signs. And this lack of sleep, lack of windows, isolation, amongst other things, can cause or worsen delirium. Also, healthcare systems are really good at addressing the acute, life-threatening stuff like a heart attack, but worse at addressing more chronic, debilitating conditions that greatly affect someone's quality of life, like chronic pain. And we're also equipped to address problems with quick fixes. For example, we frequently look to solve problems by giving fluids or antibiotics rather than providing something that would take more time and personalization, like providing spiritual care. And lastly, we fall short in addressing the factors that bring people into the hospital in the first place and ultimately could keep them from coming back. So things like housing insecurity, lack of access to healthy food, uncertain transportation, poor social support. They're all things that kind of get overlooked or deferred till a patient is just about to be discharged. And Rennie and I recognize that providers are spread very thin and work for patients to the best of their abilities to meet all their needs. And no single person is responsible for the shortcomings of the hospital. Rather, this is more addressing the system as a whole. And we acknowledge that the temple or the hospital is failing its worshipers or providers themselves. So hospitals lack free childcare, free exercise facilities, quick and easy healthy food options for its staff, and don't have options for easy, stress-free transportation. And in med school, we're taught that there are multiple components to health, such as physical, emotional, social, and spiritual needs. Um, and we want to share some ideas that other health systems have implemented that could bring us closer to meeting our mission of being a place that honors the well-being and caring for the whole patient. So here are some examples. So the farmers market at UCSF and Henry Ford here in Michigan allow patients, loved ones, staff to shop healthy, fresh produce grown locally within the hospital itself a few days a week. And this is not only convenient for patients and staff, but is sustainable and supports local farmers. Oregon Health System has a free bike valet to everyone, not just employees, and you can be taken to the different parts of the medical campus via an aerial tram, and this incentivizes people to use transportation that is a form of exercise and also is environmentally friendly. Whereas contrasting this to U of M, you can pay to rent a limited amount of covered spots to park your bike, which doesn't incentivize biking, or you could drive but not always have a reliable place to park your car and can be very stressful in the mornings. And lastly, Mass Gen in Boston has 4 on-site childcare centers and backup care options that are affordable and have flexible hours. And other health systems like Ballad Health in the South are actually extending their on-site hospital childcare centers to the larger communities to address childcare deserts. And, we can see that these hospitals are being very intentional to support its employees and patients in order to thrive both inside and outside of the hospital. And these initiatives show that promoting holistic health within a typical hospital is very possible and very valuable. But we want to hear from you guys in the audience, either in the chat or unmute yourself, what could hospitals implement that could bring us closer to meeting our mission of promoting well-being. We have a another support for bike valet in Michigan. Dr. Collier is interested in how the space itself contributes.
Yeah, I think that's Dr. Collier's point is really interesting. I went to medical school in Miami, Florida, and the physical landscape or like the structure of how the institution was built just had a lot of green spaces and access to things like that. So what would happen was there was just a lot of natural connections that people would make because they're walking in the same spaces and you're seeing colleagues, and they would do similar things like pop up food or pop up produce markets and things like that. But yeah, I think a lot of the built environment can be structured differently to, I think a lot, especially after COVID, we talk so much about like how isolated people are, and even doing things like a lot of meetings where people used to collaborate and see each other are now on Zoom. So it'd be interesting to think about how the built environment could be restructured to facilitate that human contact.
Absolutely. I feel like when you were talking, I was thinking about the atrium at the CVC, and then a few people talked about it in the chat. And that's definitely, I feel like, a place where people gather and talk, and there's music and there's like a cafe. And so I feel like that kind of is a small replication of what you were talking about at your previous institution. So we have some more windows and a few other things, having a space to be with our colleagues. More time to spend with patients. So just kind of general structure of our day could be improved. These are all wonderful ideas. Any other people want to chime in, or we can move on here? So kind of to wrap up, you know, physical and emotional health are built on tenets outside of just administering medications and performing surgeries, things like, you know, nourishing food, physical activity, connection are really important to achieve those. And, you know, I think we can all agree that our hospital system and others around the country are falling short in certain ways. And I hope that you all feel inspired that there are ways that we could improve and bring us closer to meeting our mission of caring for the whole patient and caring for our providers as well. So thank you.
I think we have a moment for a question or two. Does anyone have a question for Rennie and Meredith? Cool. Thank you.
I have a quick one, if that's okay.
Yeah, please go for it, Rod.
Hi, Remy Meredith. It's really good to meet you. My name is Rod Bravo. I'm actually an MPH student at Yale, and I love your program and everything that you guys do and preach. One thing, my discipline right now in public health is actually in healthcare management. And so when it comes to sort of innovating all these cultural changes that I agree with you are kind of needed to make healthcare run better, a lot of this conversation has to deal with having internal champions. Whether that be like clinical heads or admin heads. And so I'm wondering how, if you've ever given any thought, and I'd love to hear what you think about, how do you present these kinds?
I think you're cutting out right at the end, unless everybody else can hear. And I'm
So
okay.
I haven't led them to see this as maybe important, or that it's very subtle, but I think it's essential, and like communicating this to them, I think is something that's imperative to build like the cultural change. So I'm just wondering about how maybe you've thought about inspiring that to people who don't again have this background, but they kind of lead the charge in making changes at a systemic level.
Yeah, I can give my thoughts, and then Meredith, if you have any to add, you can sort of go after. But I think you cut out a little in the middle of your question, but I think I still understand the gist of it. I think honestly, from a student perspective, I think I still feel like I have the most or only have power kind of in the medical school space. I think the deans here are generally receptive to hearing ideas, whether or not they always carry through with them is, a different question of resources and time. But I've found that speaking to kind of leadership directly, at least within the medical school, is one way that students have been able to enact changes that are related to wellness and well-being. I think on a broader level, a hospital system is a bit harder. It's bigger than a medical school, and there's a lot more players and financial considerations. But I think in my, limited experience from a student perspective, I would hope that similar things would be possible in terms of talking to department chiefs who can then talk to the people higher up. And I think it's also just a question of numbers. If this is something only one person is asking for, then it's probably not going to happen. But if this is something that multiple key people are asking for consistently, it's more likely to end up resulting in a change. But I welcome anybody else's input as well who has more experience with actually working within a hospital system rather than from a student perspective, or if you have anything.
Just for the sake of the other presenters, I think that perhaps we should wrap it up, if that's okay. I'm sure that we could talk about this for a very long time. I'm grateful to the two of you for kind of exploring this and thinking about it. It's certainly kind of like there's something about being a student where you literally are the future of the field, and the way that you kind of imagine the world to be in the future is kind of the world that will come into being. And so I'm grateful thinking about greener spaces and thinking more thoughtfully about time. I appreciate these thoughts as mostly as jumping off points. Kind of you have your diagnosis, and then it's like, what do you do with that? I think is the question that Rod brought up. Our next presenter is Josh George. He's going to be presenting Conscience Protecting Guardrails, an interdisciplinary case study in high-risk pregnancy management. Josh is an MD, MPH, and he's a maternal fetal medicine fellow here in the OBGYN department at University of Michigan. He completed his bachelor's degree in cell and molecular biology at University of Michigan. He followed that with his MD and MPH at the University of Miami Miller School of Medicine. He then completed an OBGYN residency at DMC Wayne State University. His clinical interests are in care of high-risk patients in pregnancy, with a special focus on individuals with substance use disorders and psychiatric comorbidities in pregnancy. His current research work is centered around optimizing prenatal care for these patients, as well as translational work on cortisol regulation in pregnancy. And so, Josh George, Dr. George, take from here.
Hi, everybody. Let's see if I can get this set up properly. Okay, can you see slides and hear me? Awesome. Thank you to all of you for being here, and thanks Dr. Bruce and Dr. Collier for giving me a little bit of time to talk about a really interesting case and patient, and a lot of great discussions that have come forth from that encounter. I'm happy to be presenting today on behalf of the team, including LJ Brazier and Dr. Latak, and a couple of our students, Hannah Murphy and Shannon Clare. The title of our discussion today will be Conscience Protecting Guidelines, an Interdisciplinary Case Study on High-Risk Pregnancy Management. And hopefully throughout the discussion, what that means will be made a little bit more clear. Objectives for this discussion are to understand the principle of double effect as it pertains to medical decision-making for mothers and their fetuses, to review the concept of medical and conscience protecting guardrails, provide a basic framework of Catholic healthcare principles that were relevant to this case and may be relevant in other healthcare encounters as well, and then discuss how a team-based approach can provide benefit for not only patients, but really the team members as well. And I think that was something that was very evident through this encounter. We are in the works to present variations of this discussion at a couple different forums. So really appreciate the time and appreciate whatever feedback you might have at the end as we prepare this for future submissions. Just to go through the case presentation quickly and provide some context. Our patient was a 34-year-old G8P1 4125. And I'll break that down. I'm usually presenting to obstetric audiences, but this means that this is her 8th pregnancy. She's had 4 full-term deliveries and 1 preterm delivery and 2 miscarriages. During this pregnancy, she was diagnosed with a dichorionic or diamniotic twin pregnancy, and it was conceived via ovulation induction with a medication called letrozole. Her first trimester ultrasound was significant for a diagnosis of holoprosencephaly in fetus A, and this is a life-limiting diagnosis. Additionally to that, there was a large separate mass that was seen in the uterus, and initially on that first trimester ultrasound was suspected to be a subchorionic hematoma or a bleed into the uterus. So the patient already had come into this pregnancy with a lot of emotions, as she was excited to have twins, but then found to have a life-limiting condition for one of the twins. And unfortunately so, in the 15th week of her gestation, she experienced a spontaneous miscarriage of fetus A, which had the holoprosencephaly, and she presented to her local hospital for evaluation. Given the complexity of the ultrasound findings and the complex management that was required, she was transferred to our institution for further evaluation. Of note, she only delivered the fetus and not the placenta of the first twin gestation. Her labs were significant for pretty mild anemia. Moderate anemia with a hemoglobin of 9.1. Her TSH was on the lower end of normal. And that'll come into play as we go through a differential, and our beta HCG hormone initially at the outside institution was over 600,000 and dropped to 432,000. And just for some context, those numbers are elevated, but can be elevated in the setting of a twin gestation. I included this again just to provide a visual of kind of what we were looking at and how complex and difficult kind of making a firm diagnosis was, but just taking you through an ultrasound picture, this was suspected to be the placenta of fetus A, which had miscarried. And this large mass in the middle was what gave everybody a lot of pause, in that it was a complex mass that appeared to be separate from this third structure, which you see as the fetal head of fetus B, and an otherwise normal appearing fetus B gestation. But this mass in between gave everybody a lot of pause, and especially was initially the reason why she was transferred down here and had further imaging here in our fetal diagnostic and treatment center. Given the kind of ambiguity of the diagnosis, And what was seen, the patient was counseled on the uncertainty of the findings, but the high risk of bleeding, infection, the mass along with her labs and beta HCG opened the differential to a possibility of a molar pregnancy. And she did have 2 prior C-sections. And there were features on the ultrasound that were also concerning for placenta accreta spectrum, which is relevant as the definitive management for that condition is a hysterectomy, which would have resulted in loss of future fertility. We had extensive counseling sessions between the patient and her husband and a variety of team members, which I'll get into in a bit. The options for management that were discussed with her were a dilation and evacuation procedure, henceforth referred to as a DNE, a gravid hysterectomy, as we discussed, or expectant management. And we'll get into the reasons for each of these in a little bit more depth as we finish the case, but the dilation and evacuation procedure was just preferred by the medical team in consultation with the complex family planning service due to the high concern for placenta accreta spectrum and the concern that it would cause uncontrollable bleeding. The patient also did not prefer this option as she did not feel comfortable with this due to her Catholic faith. A gravid hysterectomy was the ultimate recommendation from the medical team, but this was ultimately declined by the patient due to a goal to preserve her future fertility. But was seen, I will add that it was seen as an acceptable option in the event that we hit the guardrails that we ultimately developed with her. She ultimately elected for expectant management of her condition with what we came up with that day as the term of guardrails, and we have continued to use that term throughout the rest of our hospital course and in our academic discussions afterwards. And what these really mean are parameters for what we viewed as safe and beneficial for the patient, but since there was a degree of uncertainty with the diagnosis and the management, the goal was to incorporate her desires, wishes, and her conscience ultimately to decide how far or how strict we would make these guardrails. On hospital day 2, the patient began to have abrupt vaginal bleeding. And she had been counseled that this was a potential option, and in the setting of heavy or life-threatening vaginal bleeding, she had agreed that this was one of the guardrails that she would not be willing to cross, and was taken to the she was agreeable to be taken to the operating room for a planned gravid hysterectomy, given the thought that this was potentially bleeding placenta accreta spectrum or a severe placental abruption. In the OR, in quite a dramatic fashion, she spontaneously, as we were preparing for the hysterectomy, she spontaneously ruptured her membranes for fetus B and delivered the entirety of the remainder of the contents of her uterus. So placenta A, the fetus and placenta B, and then a large burden of clot. She did have some complications of hemorrhagic shock due to the volume of blood loss and received 2 units of packed red blood cells, but ultimately did quite okay. And she ended up staying for a couple more days and required 1 more surgical procedure for a dilation and curettage due to some retained products of conception on hospital day 3. But on hospital day 4, she was ultimately discharged, and throughout the weeks ensuing, she had her beta HCG trended down to 0 to ensure that there was no further pregnancy tissue or no concern for a molar pregnancy. Wanted to focus in, so hopefully that sets a little bit of context for the discussion over the next few slides. The first thing I wanted to highlight is the importance of medical teams, and in this case, really to highlight how this was a non-conventional team that was brought together, but every stakeholder played a really important part to the patient. So just to highlight, moving clockwise, the medical teams included the MFM service, the complex family planning team, the gynecologic oncology team, and then the acute care surgery team assisted with her ICU admission afterwards. On hospital day one, or hospital day, one, the patient had a consultation placed to Michigan Medicine Spiritual Care. She and her husband both held their Catholic faith very deeply, and in fact, they're skipping to the next circle. Her primary obstetrician shared the same faith and used this to help build a lot of trust, and was really instrumental in helping the patient guide the patient through this difficult situation. Oftentimes, I know this is a place for providers that we see a lot of transfers in, and this relationship the patient had with her primary OB was really beneficial. A lot of times when people, at least from my experience, transfer in, we don't necessarily always incorporate their transferring physician or their primary OB. And in this case, this physician's input was really important to the patient, as they had really built a strong relationship. And then moving to the right, that physician ultimately helped to incorporate the United States Conference of Catholic Bishops, one of the initial questions that arose for us was what the patient's wishes were in terms of management, and how to manage a live fetus B in the setting of such high risk for the mother. The initial question the patient had some pretty good clarity on, of whether she would want a dilation and evacuation, and the answer to that was no, she did not prefer termination. But when it came to the question of a gravid hysterectomy, having the patient's primary OB and then some input from the US CCB was helpful to the patient to validate or help develop her own conscience. And we'll talk about what that looks like in a second. I just want to highlight the excellence of the spiritual care team and the social work team in really rallying around this patient and helping her to tease out a lot of these feelings and put them into words and communicate them back to us as the medical team, so we can make decisions together. A brief review of Catholic health directives that were pertinent to this case, but Directive 45 talks specifically about abortion, that is directly intended termination of a pregnancy before viability, or the directly intended destruction of a viable fetus, and this is viewed within this context as never permitted. Every procedure whose sole immediate effect is the termination of pregnancy before viability is defined as an abortion. This, like I mentioned, the patient had a pretty clear conscience about what that meant for her, and she was not willing to undergo any procedure that directly resulted in a termination of the pregnancy, in this case, the fetus B, which had a fetal heart rate. And Directive 47 is where a lot of the next two directives are where a lot of the tension arose, and a lot of the development over the course occurred. But Directive 47 talks about operations, treatments, and medications that have a direct purpose for the cure of a proportionately serious pathologic condition of a pregnant woman, and describes these as they are permitted when they cannot safely be postponed until the unborn child is viable, even if they will result in the death of an unborn child. This directive was helpful to introduce for the patient who, again, from Directive 45, understood that for her, a termination of the pregnancy was not an acceptable option, but this helped to clarify that a gravid hysterectomy, if which was recommended in the setting of meeting certain milestones or guardrails, that this concept helped to frame accepting that as a viable option for her. This directive helped in that. The last directive I wanted to highlight is number 53, which deals with the fact that our recommended treatment option of gravid hysterectomy would have resulted in the loss of her future fertility. So this directive states that procedures that induce sterility are permitted when their direct effect is the cure or alleviation of a present and serious pathology. And that is something that our clinical recommendation was that this is definitely a present and serious pathology that would not allow for time, most likely, or in our best estimation, to reach a gestational age of viability. And again, directives 47 and 53 helped to kind of frame and support her conscience as the act of a gravid hysterectomy and the loss of future fertility as acceptable medical options for her conscience if certain guardrails were met. This is a whole discussion upon itself, which we definitely don't have time for today, but just wanted to introduce this concept and have you think about it, as I think it really comes up a lot, not just in obstetrics, but in a lot of different fields. The principle of double effect, Thomas Aquinas introduces this principle in relation to self-defense. So we'll use this example, then I'll explain how it was placed in our context. But the original definition, it uses the example of self-defense. Nothing hinders one act from having two effects, only one of which is intended, while the other is besides the intention. The act of self-defense may have two effects, one, the saving of one's life, but the other, the slaying of the aggressor. Hopefully that's somewhat clear in that one action may have two consequences, one unintended, but this still may be a morally good or neutral act. In our case, this act was the medical recommendation for a gravid hysterectomy, that this was a morally good or neutral act, ultimately as viewed by the patient. And the bad effect, or the loss of fetus B, who was still living, was the unintended effect of the primary effect to save mom's life. Where this really came, where this really helped to form the guardrails is, although our initial recommendation was for a upfront gravid hysterectomy, this principle, I think, became more clear to the patient, and helped to realize that the option of expectant management and only pursuing a gravid hysterectomy after meeting certain guardrails was what she needed for her conscience to make this make the gravid hysterectomy a morally neutral unintended option, or a bad effect that was not the means by which the good effect was achieved. Lastly, just to touch on, sorry, I didn't realize it took so much time. This is the last slide, but the importance of the conscience that we talked about in the Catholic faith tradition, the well-formed conscience as a vessel of the voice of God becomes the ultimate arbiter of moral dilemmas, especially in those situations that are not solved by directives. And the conscience is different for everybody because it's developed through praying, learning, reflecting, and nurturing holy friendships. In this case, the patient's conscience, she had a very well-developed conscience coming into the encounter, but the different stakeholders that we mentioned earlier really helped her to form her conscience, especially in the light of really extreme circumstances. Okay. Guardrails, just to touch upon, guardrails provide a defined and agreed upon endpoint, a warning, and then some measure of safety if you meet the guardrails. So in this case, we set up clear symptoms and lab criteria such as a hemoglobin below 7 or acute vaginal bleeding, and those were our markers for definitive management. This was really helpful for the patient to say, okay, these are the things that I need to look for. And they were set in a way to allow for ample time to provide life-saving care. Delivering care once you're already past the guardrails is really difficult. So just some take-home points, and then I'll see the rest of the time. But I think it's really important to take time to incorporate valuable figures to the patient when performing multidisciplinary meetings. I think this is something that we in MFM are getting better at. To make and document clear recommendations when there is an evidence-based solution, but also to acknowledge when there's not such clarity. And then just thinking about the principle of double effect and how it can help patients think through difficult decision-making and decide what is going to be acceptable for their conscience. I'll skip the questions for sake of time. Thanks to all who helped so much with this patient's care. And thank you all for taking some time to listen.
Thanks so much, Dr. George. That's super interesting, and the principle of double effect is incredibly, I think, helpful for us as clinicians and people in the space of ethics to how to think through complex decisions. And so what a challenging case. And again, thank you to all of you who participated in caring for this person so well, including our Department of Spiritual Care, who we would be lost without. But yes, in the sake of time, Dr. George, we don't have time for questions, but again, so appreciate you being here today. Thank you. All right, so we are on to our final presenter. I have the pleasure of introducing our final speaker, Dr. Basil Saka, soon to be Dr. Basil Saka. He is an M4. He is one of our graduating medical students here at the University of Michigan, and he is soon to join Henry Ford as a urology resident. He graduated from U of M in 2019 with a bachelor's in industrial and operations engineering and spoke at both the school-wide and engineering commencement ceremonies. Following his graduation, he's worked at a healthcare engineer at Hopkins Applied Physics Lab. He's previously completed summer internships with the Center for Healthcare Engineering and Patient Safety and Amazon. And he is the co-founder and co-president of the American Muslim Medical Student Association, the largest student-led Muslim organization in the country. And his research focuses are broad, and he's interested in uro-oncology, endourology, implementation of automated dashboards, and Muslim mental health. He's passionate about community work and dreams of synthesizing technical skills and engineering with clinical medicine to improve patient outcomes. And the title of his presentation today is Resources, Discrimination, and Mental Health of American Muslim Medical Students. Basil, thanks.
Thank you so much for the introduction. It's a pleasure addressing you all today about a topic that's really interesting, and I hope we could all take something away from. So the topic of discrimination in mental health has been particularly prevalent in the last few years. We've had a number of studies published in the last few years looking at the relationship between discrimination and mental health in medicine, specifically that of people of color. And throughout all of these studies, there's really one common theme. It's that people that experience more discrimination in the workplace generally have higher rates of burnout, lower mental health within their daily life and within their profession itself. So the question we had was really, how does discrimination affect the mental health of American Muslims? This is an area that's not been studied really well, despite American Muslims, according to some estimates, making up to 15% of the national physician workforce. There was one study published in 2021 in JAMA Psychiatry that shockingly reported that US Muslim adults were 2 times more likely to report a history of suicide attempts compared to those of other faith traditions. This is incredibly kind of shocking news for our community in large, and really woke some people up to investigate this further. Another study published in 2023 kind of looked at American Muslim physicians in general and really focused on the common theme that we've been seeing in other minority groups as well, where increased scrutiny at work generally predisposes people to burnout and callousness. So when we look at Muslim medical students, which here at University of Michigan makes up a sizable proportion of our student body, we know absolutely nothing. There has been no studies, no research, not really much discussion at all about American Muslim medical students and how discrimination or their experiences at medical school really impact their journey to becoming a physician. So our objective with our study was to explore resources, discrimination, and mental health for Muslim medical students in the United States through a nationwide survey. Specifically, we wanted to look at 5 things. Number one, we wanted to look at participant demographics. Where are Muslim medical students most concentrated? Are they more in the Northeast, Southeast? What's their average age? What are they first generation? What's their ethnic makeup? These are all really important for us to just understand the population that we're evaluating in the first place. Second was to look at medical resources available. For Muslim medical students, generally with the obligation to pray 5 times a day, it can be difficult finding a place to pray within a hospital system. Do students get holidays like Eid off? Are there concessions or options available for fasting of the month of Ramadan, which could be very grueling both physically and psychologically? Number three, we wanted to look at individual spirituality in professional life. As I mentioned, Muslims generally pray 5 times a day at different times during the day. How does this correlate with one's professional life and clinical responsibilities? Four, we want to look at experiences of discrimination and mistreatment, where discrimination is broadly defined as any act of different kind of act towards a patient, some inappropriate verbal comments, or being treated unlike others. And then lastly, look at mental health of Muslim medical students. Is there any sort of anxiety, any sort of suicidal ideation, some common metrics in that space? And all of this is done within the ecosystem of the American Muslim Medical Student Association, or AMSA for short. This is the largest Muslim-run student organization in the country. It has chapters in over 170 medical schools at this point, and our national conference just this last fall in New York City attracted more than 500 medical students, giving us a really robust kind of student body to evaluate. So first, when we were looking at the demographics of American Muslim medical students, we had about a 15% response rate of about 1,800 students. So we found that our students come from all across the country, mostly centralized around the Midwest, but really almost semi-equally distributed across the Southwest and Pacific Northwest as well. We found that the most common ethnic identification was that of South Asian heritage, followed by Middle Eastern and North African. And lastly, we found that most students, about 93% of them, identified as a Sunni Muslim, which is Sunni and Shia Muslims are the two most common theological backgrounds for Muslims internationally. So what does religion really look like for American Muslim medical students? Religion means different things for different people, but one thing we're really interested in was external representation of a Muslim. And one of the most common external practices is a woman wearing the headscarf or the hijab. And we found almost 2/3 of Muslim medical students wear the hijab at school, pretty clearly indicating their religious background. Second, we looked at the number of times Muslim students pray per day. We found almost that 60% of students pray 5 times a day, and about half attend at least one congregational prayer per week, making the use of finding prayer spaces of utmost importance. And then lastly, we found that almost half of students said that an organization like American Muslim Medical Students Association has improved their mental health. AMSA has regular online programming that synthesizes spiritual backing with kind of a medical objective. We have professional development workshops, and we have opportunities for in-person community building as well. So what resources are available for American Muslim medical students? The picture that you see here might be familiar. This is, a chapel at a hospital. And this is really personal for a lot of Muslim medical students because finding a time to visit the chapel and find time to pray is really difficult. Not only is it sometimes hard to get to from various parts of the hospital, but could also be incredibly intimidating asking a resident or a faculty member that you might look up to and you want to impress that you have to take maybe 5 to 10 minutes from your clinical duties to make ablution and pray. And we found that 41% of students find it difficult to find time to pray during clerkships, which is something personally as a medical student I felt very viscerally. Now, when we talk about discrimination of American Muslim medical students, really wanted to focus on a few notable findings. The first is that about a quarter of students completely agree that the religion placed them under greater scrutiny than their non-Muslim colleagues. Now, that is how they feel. How about self-reported kind of incidences? Almost half of students have experienced at least one instance of discrimination by a classmate. And we found that maybe a possible predisposing factor is that of wearing hijab. We found that women that wear hijab are more likely to experience discrimination than women who don't wear hijab, almost by 11 percentile points. When asked how likely or unlikely do you think you'll be discriminated against in your professional career for being Muslim, almost 3/4 at least somewhat agreed with this point, showing kind of a visceral kind of embodiment of this idea that they will not be treated the same as their colleagues. Now, lastly, just want to hone this in on how this discrimination or feelings of discrimination can be related to overall mental health of Muslim medical students. I really just want to focus on one number, and that is of 13.2%. This is the percent of Muslim medical students in the United States that have had suicidal ideation during their time in medical school. This is about 3 to 4 times larger than the national adult average. But unfortunately, it's not significantly different than your average medical student. This is according to statistics from a recent JAMA article that looked at medical students internationally and found a percentage of suicidal ideation during training between 9 and 14%. Now, even though this number doesn't really set up the Muslim community different than other minority groups or other medical students in general, the reason for this number is a little bit more unique, where we found that women that wear hijab are almost 2 times as likely to have suicidal ideation than others. And given the results of other parts of the study in terms of increased levels of discrimination and whatnot, it leads us to start questioning how perhaps that external representation of their faith might be precipitating episodes of discrimination and resulting in that increased percentage of suicidal ideation. So what can we do to kind of take what we learned here and move forward in an effective and pragmatic way? The first is to encourage use of prayer spaces in the hospital settings. We found that a lot of students have difficulty finding a prayer space simply from location and whatnot. But there's also something to be said about having faculty and residents be aware that some students may have to take some leaves of absences when appropriate in the day to fulfill their necessary obligations. Number 2 is connect students with identity groups. We found that many students really appreciated a group like AMSA that provides them both a spiritual foundation as well as community and professional development resources that could help them kind of move forward in medical school, which is a challenging time for everybody. And then lastly is to include religious diversity as a pillar of DEI. Generally, in DEI conversations, I've been a part of them for many years as both an undergrad here and as a medical student. There's a lot of discussion about maybe ethnic background or identities in different spaces. When it comes to religious identity, it's very difficult to move forward, specifically in the realm of getting funding. I have been a leader in the Middle Eastern, Medical Student Association and president of the Arab Student Association in undergrad, and it was very easy to get money for events, cross-cultural kind of celebrations. But as soon as kind of try to move forward as a Muslim organization, generally it's a little bit more difficult to find the necessary grants and financial backing for that. So future directions for research, just ending off with this, is really to dive deep into seeing what more can we do to help empower these students through qualitative, semi-structured interviews. That way we could use the findings that we found here to hopefully guide conversations to make medical school a more supportive and beautiful place for all students. I'd like to acknowledge Dr. Collier for helping set up this presentation and the study, as well as our co-president at AMSA, Zachariah Authority. Happy to answer any questions.
Thanks, Basil. Fabulous. Unfortunately, friends, we don't have time for questions, but didn't our students and trainees do such a great job today? So thank you so much for coming out. And I just want to again highlight Basil, is the co-founder and co-president of the American Muslim Medical Student Association. Again, our students do such wonderful things, so inspiring to see. Thanks everybody for coming out. We really appreciate your support of our students and trainees today. And until next time, take care of yourself and others. Good to see everybody.